But since we talked about standards and we talked about protocols, as I understand it, the treatment guidelines from the American Academy of Neurology were last updated, now fasten your seatbelts here, in 2002. And they prioritized agents based on the evidence of benefits and risk-benefits ratio before the influx of all these new drugs. So how does the lack of updated guidelines affect the country's therapy or your therapy for MS? I'm guessing it doesn't for you, but it doesn't.
We've never really had guidelines that have really driven, I think, what we've done. And I don't think that the absence of revised guidelines is our greatest unmet need. I'll put it that way. I think part of the reason why there's no new guidelines is because it would be virtually impossible to do it now with the number of choices that we have. In a sense, what we've been talking about this whole time are the nuances, the fact that there are so many factors that go into the decision, patient-driven factors, disease-driven factors, comorbidities, risk profile. And we don't yet have a biologically driven way of making these decisions that would really let us have an algorithm or guideline the way there are in, let's say, oncology, which I think has done a brilliant job of being able to do this in an evidence-based way. No guideline would take into account things like patient preference, patient risk tolerance. These are the things that we spend a lot of time, I think, with our patients trying to figure out. So, I don't think there'll ever be a single algorithm. One that I like, it's not a guideline per se, but it was done by Mark Friedman's group, this Canadian treatment optimization recommendation. They did it about 10 years ago, revised it in early 2013, and it puts numbers to some of the things we've been talking about. How many relapses do you worry about? How many new lesions do you worry about? What kind of disability changes should prompt our concern? But it leaves a lot of room for improvisation and for how we use this information. And I think that's the kind of recommendation that's helpful because it doesn't tie our hands.
Stephen, I do think as MS neurologists, we've been a little bit derelict in not getting together and not trying to pull together some consensus guidelines to help treatment akin to, and we're behind them, but akin to what the rheumatologists have done in certain diseases. And I do think we have enough of a basis to get some central principles about how quickly do you want to start treatment? What prognostic factors do you think about? How are you going to judge disease activity? Some basic principles that we could come up with and agree that would be valuable.
Can we lock the door at the end of the show and make you guys do this to you?
Well, you've got us here right now. I think it's when you get guidelines that say choose X drug and then choose Y drug and choose Z drug. You run into trouble.
We could agree on principles that would be very helpful.
Some of them.
One of the principles or concepts that's emerged in recent years is the notion of no evidence of disease activity, and the things that we've talked about, MRI changes on examination and relapses, those are the things we know how to measure pretty well. And just how strictly should we be holding the response to a given treatment to that notion of NEDA, no evidence of disease activity. And it touches on the issue that you raised earlier about when do we change a medicine? And so there are those who opine that we should have a zero tolerance and we should hold people to or hold the treatment really in people to this NEDA standard.
Okay. We don't have that yet.
Can't do it.
Don't have
right?
it yet.
Can't do
We're
it.
not there.
And Stephen, you alluded to something.